Morning, everyone. Thank you for sticking around. I'd like to thank SAGES and my chairs for inviting me to speak today. Let's get into it. These are my disclosures. So we all know why we're here, right? These are things that our patients are concerned about. So this was just a quick Google search I did on hernia mesh. And if you look at the other questions that people are asking, these people are your patients, right, that are asking, is mesh safe? Should I be concerned about it? What are the side effects? So let's talk a little bit about it. So first, I'm going to go through some of the reasons we use mesh, right? Understand some of the risks associated with it and the difference between mesh and non-mesh repairs. Have a strategy for addressing these risks with your patients. And then, shocker, spoiler, if you will, I don't think surgeons are that good at communication always. And so I want to go through some basic concepts of just what good communication is, what this looks like with your patients. So why do we love mesh, right? So in ventral hernias, there's good data to support the use of it. So this is a commonly cited paper looking at as a database study cohort with over 3,200 patients comparing use of mesh either in an open or lap setting versus open repair without mesh, and the outcomes they're looking at with a 5-year risk of reoperation for recurrence and mesh complications. So what did they find? So when you're looking at the cumulative incidence of reoperations for recurrences in the non-mesh group, that was 18%, and using mesh, this dropped to 12%, so that's pretty convincing. And when you looked at the cumulative risk of reoperation, it was 17% in the non-mesh group, and that dropped to 11% in the mesh group. But obviously there's reasons we don't love mesh, right? There are complications associated with it. So in that same cohort, 1.4% of those patients required reoperation for bowel obstruction or perforation or bleeding. And then 2.7% more patients required subsequent reoperation compared to that non-mesh group. Okay, well, what about inguinal hernias? So we're going to be focusing on the most common mesh repair, the Lichtenstein repair, not referring to plugs when I'm talking here. I'm not an advocate for plugs. Just say no, they're evil. And then what about tissue repairs? Obviously, there's a variety of different repairs. I think it's important that you are familiar with at least one of them. I'm not saying that necessarily you should offer that to all your patients if you can't do it in some kind of high volume way or feel comfortable doing it. But certainly we should all know one for emergent need or have someone that you know you can refer to that can offer that to your patients. If you're not familiar with these and you need an education on it, or if you teach residents like I do and you need a good reference for it, one of our chairs, Dr. Tofi, has written an excellent review on some open options for inguinal hernia that I suggest you look at. So what about recurrence between these two? So this was a randomized clinical trial of non-mesh versus mesh in primary inguinals, multi-site study, 3-year follow-up, included over 289 unilateral hernias, and they looked at the non-mesh versus the mesh. You can see there's a big variety in those groups, which is always kind of a downside when we're looking at hernia studies, as it's hard to standardize. But what they found, with pretty good retention in that there was no difference in quality of life scores, pain, or complication rates. When it came to recurrence, the non-mesh group, there were 9, and in the mesh group, there were 1, but it was kind of funny. I don't know who messed this up, but that 1 was actually a vicral mesh, so not shocking. Overall, though, the 3-year cumulative recurrence rates were 7% in the non-mesh group and 1% in the mesh group, so pretty convincing case there. Also of note, just kind of fascinating, that when they stratified those recurrences to less than or greater than 65, there was a big difference, 3% versus 16%, which to me means ultimately it's not always our fault, right? Sometimes you can blame the patient. There's characteristics that are at play here. Patients don't necessarily care about recurrence, right, though, because they don't know. They just assume they're not going to have a recurrence. What they do care about and they hear about is pain. So what's the difference in these? So another randomized controlled trial, multi-sites, and they looked at unilateral hernias, had over 300 patients. For the non-mesh group, the surgeons were able to choose whatever repair they were most comfortable with. And for the mesh, it was a polypropylene mesh. And primary outcome looked at was the persistent pain at 10 years out. And what they found is that there was no difference in long-term chronic pain between the two groups. And also kind of interesting is that the people who did have pain, it did seem to dissipate over time. So maybe we can provide some reassurance to our patients that if they have pain, it might at least get a little bit better. And what about type of mesh? I like to stress to my patients that not all meshes are created equal, and that the meshes we use today are not necessarily the meshes that we used 15 years ago, right? And so when you look at the different types of mesh and you're comparing heavyweight versus lightweight in this study, this was a follow-up of a previously published randomized controlled trial, and again, looking at heavyweight versus lightweight, had really good long-term follow-up, and then they sent these patients questionnaires and compared this to a registry. And after exclusions and actually getting surveys back, they ended up with two groups, 121 in the heavyweight and 150 in the lightweight. And what they found is, first I want to note, is that overwhelmingly these patients do well. So a huge percentage of them had no pain, right? But when you look at the comparison, that there was definitely a favor, significantly so, for the lightweight mesh group, which is why most have gone away from using any kind of heavyweight mesh. Other notable results, that when you look at the immediate postoperative pain, the values were slightly higher in the heavyweight mesh group. Probably not surprisingly, there was a significant difference in the perception of that foreign material in the heavyweight group. But there was no significant difference in the patient-reported recurrence or overall satisfaction. Okay, what about complications? So this was a Cochrane database review. Ultimately, 25 studies were included, over 6,200 patients, and these were the take-homes. So mesh repair probably reduces recurrence rates. That was moderate quality evidence. Neurovascular and visceral injuries were more common in the non-mesh repair group. Noting, again, none of these surgeries are risk-free, right? Wound infection, not surprisingly, slightly more common in the mesh repair. Seroma is more frequent in the mesh repair. But also note that the patients who had mesh actually got back to their activities of daily living a little bit faster. Okay, so a lot of data there. How do you have this discussion with your patients ultimately? Again, I think you should kind of focus on good communication, so I want to review what we call the C's of communication. So first, you need to be credible. Some of that we have automatically, right? We have our degrees, the patient's already coming to see you because they believe in some kind of expertise, but you need to be able to demonstrate that competency, and I know we hate it, but ultimately, you have to put in the time, right? Spend the time with the patient, explain to them what a hernia is, why you recommend that you fix it, what the mesh is, and some of it's giving it some personal reference to what you're doing. So I'll often say, like, look, I've repaired a lot of hernias and I put a lot of mesh in a lot of patients, and these are the things that I'm concerned about. Context, you can't pretend that you don't know what they're seeing, right? You have to acknowledge the reality of the environment. Hey, I know that these are the things that you're seeing right before you come into my office, right? Content, so your message should have meaning and relevance. So explain why you're recommending it, and also explain what it is. I think it's important to understand that patients don't really know what mesh is. They just hear these commercials and they're afraid of it. But I almost always have multiple examples of meshes that I carry around in my white coat pocket, and I pull them out and I let them look at it and I let them feel it. And surprisingly, that actually relieves a lot of concerns for patients because they find out it's not like the heavy metal plate that they were imagining. Clarity, keep it simple, right? You need to use terms they understand and explains terms. Like, they may not know what a recurrence is, so everything along the way kind of explaining what you mean. And I don't necessarily recommend quoting studies because that may not mean much to them. I think it's more important to kind of share your outcomes and put it in a framework that they get. So I'll often say, hey, I've been at Hopkins for 5 years, and in that 5 years, these are the outcomes that I've experienced. Continuity and consistency. This won't apply to every patient. Our best case scenarios, they come once, we get to operate and they're gone, right? But that doesn't always happen. So some of these patients are concerned and they need that repetitive message. And I think this is, given the current medical legal environment, one of those situations where you should take the extra time for your own well-being and for that patient to make sure that when you go into the operating room, everyone is on the same page. And so these are the patients that if I get afterwards, an EMR message that says, hey doc, I really wanted to ask you another question about this mesh. I don't address it on there. I immediately schedule them a follow-up appointment, or in today's world, nice, a virtual follow-up, right? So I can address those and document that I address those, and everyone feels happy about the decision made. Channels. So understand how to communicate to your audience, which in this case is your patient, right? And so they won't always necessarily take in everything you said to them right at that point. And so I think it's important to have a website that you can reference. They can get more information, read about it later. Maybe a patient handout, a little antiquated today. Something we've been working at is actually working towards QR codes. That's a nice way they can scan it and get more information and take it home with them. And then, of course, some people like Dr. Tofai are excellent about going above and beyond and using social media, right? Kind of taking a more offensive approach and reaching out to patients and trying to educate them ahead of time, which we all benefit from. And then finally, the capability of your audience. So make sure you understand who you're speaking to. Understand that they have a different level of knowledge. They may have a level of trust in healthcare. And all of this is going to be influenced by their personal and family experiences and their beliefs and attitudes. So ultimately, this is my spiel. Complications happen, right, whether there's mesh or not. These are the actual things that I worry about with mesh. Explain that not all meshes or surgeons are created equal. And so if you're going to have a hernia repair, it doesn't necessarily have to be me, but please at least go see someone who knows what they're doing and is knowledgeable in these things. And explain that, yes, one potential outcome is that mesh could need to come out. And ultimately, despite those things, this is why I would still choose a mesh repair for my family. And remember, be transparent. It's okay to offer alternatives, so not necessarily a tissue-based repair. It may be discussing bioresorbables, biologics in patients that are really concerned about permanent synthetic meshes. Know that patients do overall trust us. And also, in the end, it's not my job to convince them to have mesh. So if you have someone that is just completely against it, the options are to offer them a tissue-based repair, or if you don't think that's the best thing, then to refer them to someone else to have a second opinion on it. So these are the things we talked about, and sake of time, I'll end there. Thank you so much.